When was the last time you took off your shoes and really looked at your feet? Not glanced at them. Really looked, examined them the way you would examine something that was trying to tell you something important. Most people never do. But the feet are easy to ignore. They are at the bottom of the body, out of easy sight, and unless they hurt or cause a problem, they rarely demand attention. We cover them up every morning and uncover them every night, and in between, we largely forget they exist. But here is what I have spent more than 20 years trying to communicate to my patients, and what I want to communicate to you today. Your feet are one of the most sensitive monitoring systems in the entire human body. And the thing they monitor most clearly, the thing they begin to signal earliest before your blood tests show it, before you feel it anywhere else, is how your body is handling blood sugar. I am Dr. John Miller, an endocrinologist with over 2 decades specializing diabetes and metabolic disease. And I need to tell you something I believe with absolute certainty after all those years in practice. The diabetes epidemic we are living through is not primarily a failure of medicine. It is a failure of information. People are developing serious complications from a condition they did not know they had, from a condition whose early warning signs they were never taught to recognize, from a condition that was quietly announcing itself in their feet for years before anyone thought to look. Today, that changes. I am going to walk you through 9 specific warning signs that appear in the feet before diabetes is formally diagnosed, or in people who have been diagnosed but whose condition is not as well controlled as it should be. 9 signs that are real, that are specific, and that most people experience and dismiss as something else entirely. By the time we finish, you will have the information, and information is always the beginning of power. Stay with me through all 9, because at least one of them, I am almost certain, is something you have already noticed and not yet acted on. Before we go through each sign, I want to give you the foundation, the biological reason why the feet are affected first, and why the signs look the way they look. Because once you understand the mechanism, the signs stop feeling random. They start feeling like a logical message. In type 2 diabetes, the form that develops gradually in adults and accounts for over 90% of all cases, the body develops what is called insulin resistance. Insulin is the hormone that acts as a key at unlocking cells so glucose can enter and be used as fuel. In insulin resistance, the cells stop responding to that key normally. The pancreas compensates by producing more and more insulin. For a while, blood sugar stays near normal, but only because the pancreas is working enormously hard to keep it there. This compensated phase can last for years, and during that entire time, the high insulin and the occasional blood sugar spikes after meals are doing damage, specifically to the smallest blood vessels and the peripheral nerves. That damage appears in the feet first for 2 reasons. First, the feet are the furthest point in the body from the heart. The capillaries that supply them are the tiniest in the circulatory system, vessels so narrow that a single red blood cell barely fits. These capillaries are the most vulnerable to glycation, the process by which excess blood sugar binds to proteins in blood vessel walls, making them stiffer and less functional. In the large arteries of the heart and brain, this process takes decades to produce obvious consequences. In the tiny capillaries of the feet, it produces measurable damage much sooner. Second, the nerves that carry sensation from the feet to the spinal cord are among the longest nerve fibers in the entire body, traveling almost a meter in a person of average height. Long nerve fibers require consistent metabolic support along their entire length. When that support is disrupted by elevated blood sugar, the damage appears first at the longest fibers, and therefore first at the farthest points, the toes, the feet. Vascular damage and nerve damage. These 2 processes, running simultaneously and silently over years, produce every single one of the 9 signs I am about to describe. Now let us go through them, one by one. Sign number 1. Tingling or numbness that comes and goes, particularly at night. Think back to the last few weeks. Have you been lying in bed, ready to fall asleep, and noticed a tingling in your toes? A sensation like mild pins and needles. Not painful, not alarming, just present. Maybe it lasted a few minutes. Maybe you shifted position and it faded. Maybe it came back the following night in exactly the same spot, and you noted it briefly and then went to sleep. That sensation is not nothing. That is the earliest detectable sign of peripheral neuropathy, nerve damage caused by elevated blood sugar, and it is the sign that goes unaddressed for the longest time, precisely because it is intermittent, painless, and easy to explain away. Here is what is actually happening. The myelin sheath, the protective coating around the nerve fiber, has been damaged enough that the fiber is no longer transmitting signals with complete accuracy. The nerve is still functional, still connected, but the insulation is fraying, and a fraying electrical wire does not fail completely all at once. It works most of the time, and then occasionally, particularly under conditions of reduced circulation, which is exactly what happens when you lie still, it sends a garbled signal, a buzz, a tingle, a brief sensation that your brain correctly identifies as coming from the the foot, even though nothing is touching the foot. This happens preferentially at night because lying flat reduces the gravity-assisted blood flow to the feet that exists when you are upright and moving. The already marginally supplied nerve fibers receive even less blood during rest, and the reduced metabolic support triggers the intermittent signal distortion. The quiet of the night also makes the sensation perceptible when the noise of the day masked it. What I need you to understand is that intermittent does not mean mild. It means early. The nerve is damaged enough to produce symptoms some of the time, but not yet damaged enough to produce them constantly. This is the window where the damage is real but not yet irreversible, where bringing blood sugar under control can stabilize the nerve and allow partial recovery. The tingling is a message from that window, asking you to act while it is still open. The test you need is simple: a fasting blood glucose and a hemoglobin A1C. At 2 numbers, 1 blood draw results within days. If you have been noticing tingling in your feet at night, even occasionally, even mildly, please get that test. Type 1 in the comments right now if this is something you have been feeling. I read every comment, and I want to know how many people watches has been carrying this sign without acting on it. Sign number 2, a burning sensation on the soles of the feet, especially in the evening or at night. This is related to sign 1, but distinct in an important way. Where tingling is the result of a partially damaged nerve sending intermittent distorted signals, burning is the result of small fiber neuropathy, where the tiniest nerve fibers, the ones that carry pain and temperature sensation, become not just impaired but hyperactivated. When these small fibers are damaged, they do not simply go quiet. They become irritable. They begin firing spontaneously without any external stimulus, because the normal inhibitory mechanisms that regulate their activity have been disrupted. The result is a sensation of burning or heat in the absence of any actual heat or injury. The nerve is generating the signal on its own, from damage, not from reality. People who experience this describe it consistently: a warmth on the bottom of the foot, a low, persistent burning, not sharp, not stabbing, but there, reliably there, especially in the hours after dinner and into the night. Some need to put their feet on a cool tile floor for relief. Some sleep with their feet uncovered even in cold weather because the warmth of blankets against the sole is unbearable. I had a patient, a 67-year-old retired nurse named Helen, who had dealt with this sensation for nearly 3 years. She attributed it to menopause-related circulatory changes, to a brief period of heavy exercise, to a vitamin deficiency she had read about online. She tried different socks, different creams, different mattresses. She never had her blood sugar checked in relation to this symptom, because no one had told her that blood sugar and foot burning had anything to do with each other. Her A1C was 7.4%. She had had diabetes undiagnosed for at minimum 2 to 3 years. The burning sensation is worse at night because the drop in core body temperature that accompanies sleep affects already sensitized nerve fibers in a way that increases their spontaneous activity. And the absence of daytime distraction means the brain allocates more processing to body-based sensation. What was background during the day becomes foreground in the quiet. A burning sensation in the soles of the feet, present for more than a few weeks, not explained by a known injury or new medication, is a clinical signal. It belongs in a conversation with your doctor, and that conversation should include blood sugar testing. Sign number 3, dry, cracking skin on the heels and soles that does not respond normally to moisturizer. I want to be honest about this one. Dry skin on the feet is extremely common, and most cases are benign: low humidity, prolonged standing, natural reduction in skin oil production with age. Not every dry heel is a diabetes warning sign, but there is a specific quality to the dryness that accompanies autonomic neuropathy, nerve damage affecting the automatic, involuntary functions of the body, that is different from ordinary dry skin and worth understanding. Your feet have a built-in self-moisturizing system. The autonomic nerve fibers that regulate the sweat glands of the feet, and there are more sweat glands per square centimeter on the foot than almost anywhere else on the body, continuously modulate sweat gland output to maintain skin hydration and elasticity. This is not the sweating you notice during exercise. It is a constant, subtle, unconscious process. When these autonomic nerve fibers are damaged by chronically elevated blood sugar, the sweat glands of the feet become underactive or entirely inactive. The skin loses its primary internal moisturizing mechanism. No amount of external lotion fully compensates, because the dryness is not caused by insufficient lotion. It is caused by insufficient nerve signal reaching the sweat glands. The pattern is typically most severe on the heels and balls of the feet, the weight-bearing surfaces where mechanical stress is highest and where the combination of pressure, friction, and lost moisture leads most quickly to deep fissuring. And in a foot with even partially impaired nerve sensation, these fissures may not be as painful as they should be, which means they can become significant open wounds without the alarm of pain prompting action. Dry, cracking skin that is disproportionate to your general skin health health elsewhere, worsening gradually over 1 to 2 years, not responding to moisturizer, and appearing alongside any other sign on this list. That combination warrants metabolic screening. Sign number 4. Color changes in the feet or lower legs. I want you to do something right now. Remove your shoes and socks if you have not already, and look at the skin of your feet and lower legs. Is the color the same as the skin higher up your leg? Are there patches of unusual pallor, areas paler than they should be? Is there a reddish or purplish flush, particularly in the toes? Now try a simple test. Let both feet hang off the edge of your chair or bed for 2 to 3 minutes, then elevate them above the level of your heart, supported by pillows, and watch for color change. In a foot with healthy circulation, color should remain consistent whether the foot is dependent or elevated. In a foot with compromised arterial supply, you may see a reddish or purplish flush when the feet are hanging, called dependent rubor, and a rapid pallor, a blanching, when they are elevated. This pattern is a clinical sign of a peripheral arterial disease, the narrowing of the arteries that supply the legs and feet. And diabetes is the single most powerful accelerant of peripheral arterial disease known in vascular medicine. The mechanism is multifold. Glycation stiffens the arterial walls. Elevated insulin promotes the growth of smooth muscle cells that narrow the arterial lumen. Chronic high blood sugar creates a pro-inflammatory state that accelerates plaque formation, and microvascular damage reduces the collateral circulation that would otherwise compensate. The feet, at the end of the longest arterial pathways in the body, show the consequences earliest and most dramatically blistered pallor of the toes, dependent rubor that reverses to pallor on elevation, or a bluish discoloration of the toe tips that is not related to cold. Any of these, in an adult over 50 who has not had recent metabolic screening, warrants that screening promptly. Not as an emergency unless accompanied by severe pain or sudden onset, but promptly. Sign number 5. Wounds on the feet that heal slowly. Cuts, blisters, or sores that linger far longer than they should. Think carefully. In the past year or two, have you had a blister, a small cut, or a sore on your foot that surprised you with how long it took to heal? Not necessarily dramatic, sometimes just the vague sense that the skin is no longer bouncing back the way it once did. That a minor wound that would have resolved in days at 40 is taking weeks at 65. Wound healing is one of the most metabolically demanding processes the body undertakes. It requires an adequate inflammatory response, sufficient blood supply, a functioning immune system, and the ability to grow new tissue. Chronically elevated blood sugar disrupts every single one of these steps. The inflammatory response is dysregulated. The blood cell supply to the wound site is compromised by microvascular damage. The immune cells, neutrophils, and macrophages are directly impaired by high glucose, reducing their ability to prevent bacterial colonization. And the growth of new tissue is slowed by glycation of the structural proteins involved in collagen synthesis. The result is a wound that heals at a fraction of the normal speed. That seems stuck, crusting, appearing to heal, then reopening. That becomes slightly reddened around the edges as infection establishes in tissue the immune system cannot adequately defend. I want to be direct about the stakes here. Diabetic foot ulcers are the leading cause of non-traumatic lower limb amputation in the developed world, and the pathway from a slow-healing blister to an amputation is not a dramatic sudden event. It is a slow accumulation of unrecognized signals, a blister dismissed, a wound treated at home because it did not seem serious, a foot that could not feel the wound worsening because the nerves that would have signaled pain were already impaired. The guideline I give my patients: any wound on the foot that has not shown clear improvement within 2 weeks needs a physician's eyes on it. Not next month, within 2 weeks. Because in a foot with compromised circulation and sensation, you may not have the early warning signals, pain, visible progression, that would normally tell you the wound is becoming serious. Sign number 6. Fungal infections of the feet and toenails that keep coming back. Thickened, yellowed, brittle toenails. That itching between the toes that responds to antifungal cream and then returns within weeks or months. If this has been your experience, recurring fungal infections despite consistent treatment, there is a biological reason most people are never told about. Dermatophytes, the fungi responsible for most foot and nail infections, feed on keratin, the protein in nails and outer skin. But like all living organisms, they also require glucose for their metabolism. When the glucose concentration in skin and nail tissue is chronically elevated, as it is when blood sugar is persistently above normal, these organisms have a constant, abundant food source that dramatically accelerates their growth and makes colonies vastly harder to eradicate. The antifungal medication reduces the surface colony, but it cannot change the metabolic environment. When the medication stops, the colony reestablishes itself from residual organisms in an environment that is, if anything, more hospitable than it was before. The skin's immune surveillance is also reduced by elevated sugar through the same mechanisms that impair wound healing. Fungal colonies that a fully functioning immune system would contain and eliminate are instead tolerated and allowed to spread. If you have completed more than 2 courses of antifungal treatment for the same infection without a sustained clear period of at least 6 months, that recurrence pattern is significant. The question is not which antifungal works better. The question is whether the underlying metabolic environment is making any antifungal less effective than it should be. A metabolic evaluation, blood sugar A1C is the place to start. Sign number 7, loss of hair on the tops of the feet and the lower legs. This is the sign that generates the most surprise because it requires looking at the feet with attention most people never apply. Try something right now. Look at the top of your foot. Is there hair there? Has there always been hair there, and is it still present? Look at your lower legs from ankle to midcalf. Is the hair there the same density as higher up the leg? Has it thinned gradually in a way you perhaps noticed but did not think much about? Hair follicles are among the most metabolically demanding structures in the skin. Each follicle undergoes continuous growth cycles that require substantial energy, oxygen, and nutrients delivered by capillary blood supply. The follicles of the feet and lower legs, at the end of the longest arterial pathways in the body, are among the first to experience the effects of impaired peripheral circulation. When arterial supply to the foot and lower leg is compromised by vascular damage from elevated blood sugar, the body makes a rational metabolic decision. Hair growth is non-essential. In a circulatory environment where resources are scarce, available blood flow is allocated to tissues that cannot afford to go without: the nerves, the muscle, the skin's immune and repair functions, and it is reduced to the hair follicles. The follicles, deprived of adequate perfusion, enter a prolonged resting phase. New hair does not grow. Over months and years, the hair that was there simply is not replaced, and the skin of the lower leg and foot gradually becomes hairless. This process is painless, gradual, and entirely without discomfort, which is precisely why it is overlooked. There is no symptom to report. There is only an absence. Loss of hair on the feet and lower legs in the absence of a known cause is a quiet, persistent, painless sign of peripheral arterial insufficiency. In an adult over 50 without recent metabolic screening, it belongs in the same conversation as everything else on this list. Sign number 8. Foot or lower leg pain that is worse at rest and better with walking. This sign is counterintuitive enough that I want to make sure you hear it correctly. Pain that is worse at rest, specifically, pain in the foot or lower leg that arrives in the evening or wakes you at night, and that relieves somewhat when you stand up or walk, is a specific vascular pain pattern called ischemic rest pain. In a leg with significant arterial disease, the narrowed, stiffened arteries that result from years of elevated blood sugar damaging the vascular walls. Blood flow is borderline even at rest. When you lie down and the heart no longer has gravity assisting delivery to the feet, that borderline flow becomes insufficient to meet even the resting metabolic needs of the foot's tissue. The result is an aching, cramping, or burning pain in the foot or calf that begins at night. Walking relieves it temporarily because the muscular contractions of walking act as a supplemental pump, physically pushing blood through the narrowed vessels by mechanical force. Many people who experience this develop habits: sleeping with feet hanging off the edge of the bed, getting up to walk briefly when the pain wakes them, sitting with feet on the floor rather than elevated. These are compensatory behaviors that the body develops intuitively because the dependent position uses gravity to assist compromised arterial flow. They provide real, if temporary, relief, but they do not address the underlying problem. In vascular medicine, ischemic rest pain is classified as critical limb ischemia, the most advanced clinical stage of peripheral arterial disease before tissue loss begins. Its presence indicates the arterial supply is chronically insufficient at the resting baseline. Without intervention, the next stage, non-healing wounds, tissue death, amputation, is a foreseeable progression. If you have been waking with foot pain that walking relieves, please bring this to your doctor. Use those exact words. The pain is worse at rest and better with movement. Any trained physician will understand the significance and order the appropriate evaluation. Sign number 9. Changes in the shape of the foot or toes. Toes that have begun to curl, or prominent calluses forming in unusual locations. The idea that diabetes can change the physical architecture of the foot surprises most people. Most understand that diabetes affects sensation. Some understand it affects circulation. But the idea that it can alter the actual shape and alignment of bones and joints, that is something very few people have been told. The foot's architecture depends on a precise balance between the muscles that flex the toes and the muscles that extend them. The small intrinsic muscles of the foot, housed within the foot itself, maintain this fine-tuning. They are also among the first muscles in the body to be affected by peripheral motor neuropathy, the nerve damage that affects motor control as well as sensation. When these muscles weaken and atrophy, the balance is lost. The flexor tendons, which pull the toes downward, are physically stronger than the extensor tendons that pull the toes upward. In a healthy foot, the intrinsic muscles provide the counterbalancing force that keeps the toes straight. When those muscles weaken from neuropathy, the flexors win. The toes begin to curl, bending downward at the first joint. This is a hammer toe, not a footwear problem, not simply a genetic tendency. In many cases, when it develops in midlife and progresses gradually alongside other foot signs, it is the motor expression of peripheral neuropathy. The clinical importance goes beyond appearance. Hammer toes and claw toes create pressure points, areas where the deformed toe presses against the shoe or the ground with concentrated force. In a foot with intact sensation, these pressure points produce pain and the person adjusts. In a foot with compromised sensation, they produce calluses silently. The callus builds, the pressure beneath increases. Eventually, the tissue beneath the callus breaks down and an ulcer forms, directly beneath what appeared to be protective thickened skin. If you have noticed your toes changing shape over the past several years, becoming more curled, more rigid, harder to straighten, or if you have developed prominent calluses in locations you did not previously have them, please consider this not as an isolated podiatry problem, but as a potential neurological sign that belongs in a broader metabolic conversation. 9 signs. We have been through all of them. I want to close with something I believe deeply after more than 20 years in this field. Diabetes does not arrive as a sudden event. It arrives as a slow accumulation of changes in the vessels, in the nerves, in the tissue that take place over years before a blood glucose number ever crosses the diagnostic threshold. The feet are where that accumulation becomes visible and sensory earliest. And every one of the 9 signs I described today is present in that early to middle window. The window where the damage is real but not yet irreversible, where intervention can change the trajectory of the next decade of your health. Most people miss that window, not because they were careless or uninformed in some personal failing way, but because nobody told them what to look for. The appointment is 12 minutes. The feet are rarely examined. The questions about tingling and burning and wound healing are rarely asked. The information exists in medical textbooks. It simply does not reach people in time. I had a patient named Dorothy, 64 years old, sent to me by her daughter who had found information like this online. Dorothy had 3 of the 9 signs: tingling at night, recurring athlete's foot that would not stay gone, and heel cracking that had been worsening for 2 years. She had attributed all 3 to getting older. Her A1C came back at 6.8%, pre-diabetic technically, but on the edge. We adjusted her diet, added a walking program, addressed the foot signs directly. 6 months later, her A1C was 5.9. The tingling was gone. The athlete's foot had not returned. She said to me at that appointment, "I had no idea my feet were trying to tell me something. I thought they were just aging badly." They were not aging badly. They were communicating perfectly. She just needed someone to give her the vocabulary. You have it now. Use it. Before you go, I have a genuine question for you. Which of the 9 signs we discussed today have you recognized in yourself or in someone you love? Type the number in the comments. 1 number, or several, or none if everything looks clear. I read every single comment on this channel, and your answer matters. It helps me understand what people are actually experiencing, and it may be the thing that prompts someone else who reads it to make the appointment they have been putting off. If this video gave you something real today, something that explains a symptom you have been carrying without understanding, please share it. Send it to a parent, a spouse, a friend who is over 50 and has not been screened recently. This information does not reach people through the healthcare system quickly enough. The only way it reaches them is through people like you who watch something like this and think of someone specific and decide that person should know. Subscribe to this channel. Next, I am going to cover the 5 foods most aggressively spiking blood sugar in people over 60. Foods often marketed as healthy, recommended by well-meaning nutritionists, and producing metabolic damage in millions of people who have no idea. You will not want to miss that.